start the group in this room, in F102. You'll start here at 7:30 in the morning on both days. But half of you are here tomorrow, the other half will be here on Wednesday. So just check your clinical rotation schedule to see which day you are on campus. There are some activities she wanted you to do before. There's a labs tab in Blackboard. There's a short PowerPoint to listen to in advance, but go into the lab tab tonight, take a look at any activities you have to do in advance. Okay, so we're going to pick up with slide 27, I want to say. Yes. All right, so we're going to walk through 10 case studies together. I think the most challenging part with ABG analysis is really figuring out if it's fully compensated, partially compensated, or no compensation. By the time we get through these 10 case studies, I promise you, you will have it. I promise. It'll be very fuzzy at first. You'll think, what is she talking about? But as we go through more and more, and I'm going to repeat things over and over and over so I know that you have it. I'm going to be trying to go, emphasis on trying, to go between the doc cam and the PC so that you can see a little bit better. So we're going to start here on slide 27. Let me just make that bigger for you. Okay. Oh, sorry. All right, so just find it on your handout in front of you, and then I'm going to flip to the document camera. Everybody on the right slide, 27? Okay. Case study 1. I'm going to flip back to the doc-cam. We're going to walk through this together. So, we have somebody, let me get something to write with. They're, let me get something without jumped on it. Okay, so the pH here is 7.18. Remember that we said the normal course is 7.35 to 7.45. The higher the number, the more alkaline or base, we're going to give it a B. The lower number, the more acid or acidosis. PaCO2 measures our respiratory function, right? The lungs compensate quickly. This is an acid, so the higher the number, the more acid, we'll give it an A. The lower the number, the more base, we'll give it a B. The PaO2, basically where it correlates here is the PaCO2 really measures somebody's ventilation, how well they're breathing, either they're hypoventilating or hyperventilating. The PaO2 measures their blood oxygen level. Okay, we're going to talk more about that, certainly with COPD and your cards on Thursday. But it is part of the ABG. And then the bicarb, the piece of the puzzle here, this is your renal function. We call it metabolic. This is the one that's slow to compensate. It takes 2 to 3 days to compensate, but once it compensates, it can hold that compensation for a long period of time. Normal here, 22 to 26. Because it is a base, the higher the number, we're going to give it a B for base and the lower number an A for acid. And then just in general, I put it on each slide, it's fully compensated only if the pH is within normal limits. There's partial compensation if the remaining value is in the opposite direction, and I will show you that again and again until I know you have it. And then there's no compensation if the remaining value that's hanging out there is within normal limits. So let's walk a few through. So this first one, the pH is 7.18. So guys, am I going to give this an A or a B? A. I'm going to give it an A. Good. Thank you. The PaCO2 is 38. Where does that fall? So it's within normal. And of course my Sharpie dies 3 seconds in. All right, and then the PaO2, 70. So that's actually mild hypoxemia. So you know, the PaO2 normal is 80s and above, 70s is mild, 60s is moderate, and 50s is severe hypoxemia. So this one we said was 70, so it's mild. All right, and then the bicarb is 15, so where does that fall? A, so we're going to give it an A. So now here's the trick. Which one follows in the same direction as the pH that we look at first?
Metabolic.
The metabolic, so we know it's metabolic acidosis, right? Now we got to figure out, is it fully compensated? No. How do we know that? pH is not within normal limits, right? Okay, so now we have to figure out, is it partially compensated or no compensation? If it was partially compensated, guys, this remaining value should be moving in the opposite direction of the other two in an effort to buffer. Is it moving in the opposite direction?
No.
No, so it is no compensation. Okay, I know it's fuzzy, it's going to come into focus, I promise. All right, let's do another. And this next one is, back. So this is case study number 2, just so you have your right one up. The PaO2, where it fits into the puzzle is the PaCO2 reflects the ventilation, how they're breathing. The PaO2 is how their blood is oxygenating. So in other words, if they have like a PE, their ABGs might look normal except for that PaO2. So it is an important piece of the puzzle.
So for the interpretation of it, after this,
No. All right, thank you. Good question, though. All right, guys, so we're on case study number 2. If I forget to flip back to the document camera, you're just going to have to tell me. Don't get old. All right, so let's look at case study number 2. So we've got a pH of 7.6. Where's that fall? Are we going to give it an A or a B?
B.
B, right? It's high. This is base. So we're going to give it a B. We've got, let's see, a PaCO2 of 30. So where's that fall?
B.
B, right? Okay. Our PaO2, I don't know, what's our PaO2 is 60, so that's moderate. Thank you, whoever said it. All right, and then our bicarb 22 to 26, and this is where's the bicarb 22. So it's within normal, right? Low end, but within normal limits. So the main problem is whichever value follows the same direction as the pH. The pH here is base. What follows in the same direction?
Respiratory.
So this is respiratory alkalosis. Very good. Respiratory alkalosis. Now the hard part, the part that makes our head hurt a little. Is it fully compensated?
No.
Nope. How do you know?
pH is not within normal
pH
limits.
is not within normal limits. Excellent. Now, for the trickier part, is it partially compensated?
No.
No, and we know it's not partially compensated because our third value is within normal limits. If there was partial compensation, that would be moving in the opposite direction. All right, so this would be somebody probably hyperventilating. All right, let me go back here. Stay with me. I swear to you, the fog will clear. I promise. Stay with me. Stay with me. All right. So this is case study number 3. All right. Case number 3. So the pH is 7.58. What are we going to give it?
B.
B. Very good. Our PaCO2 is 35.
Within normal limits.
Within normal limits. Good. PaO2 is 75, so mild. And then our bicarb is 50.
B.
So B, so So what follows in the same direction? So it's a metabolic alkalosis. Good. Is it fully compensated?
No.
No. Our pH is not within normal limit. Is it partially compensated?
No.
No, because our remaining value is not moving in the opposite direction. It's within normal limits. Okay, very good. So, metabolic alkalosis, no compensation. Isn't this fun? Yeah. All right, so this is just to make sure we're all on the same slide. Sorry, that's not what I wanted to do. Why did the PC
Just the third.
All right.
But that's what I was asking. Okay, I got that.
And now let me go back to the PC. I don't know why it's not going back to the PC, guys, and I apologize. But just to, we're going to move on to case study number 4. Number 4, it's on the top. You see it's being stubborn for some reason. Okay. Case study number 4 on your handout. All right, so our pH here is 7.28. What are we going to give it? A. Our PaCO2, norm's 35 to 45, our CO2 is 28. B. PaO2, what's our PaO2? 70, so mild. Yeah, good. And then our bicarb is 18. A. So what follows in the same direction as the pH? So metabolic acidosis. Fully compensated? No. Our pH is not normal. Is there partial compensation? Yes, this is our first example of partial compensation. We know it's partially compensated because the remaining value is moving in the opposite direction of the other two. Okay, case study number 5. Our pH is 7.33, so what are we going to give it? A, good. Somebody up there really loud. PaCO2 is, case study number 5 is 67. A, agreed. Our PaO2 is 47. Ick, severe. Yeah. And then bicarb is 37, so what are we going to give that? A B. What follows in the same direction as the pH? Respiratory, so it's respiratory acidosis. This is your classic COPD here. We know it's not fully compensated, right guys? pH is not within normal limits, so we know it's not fully compensated. But we know it is what? Based on partial, right? Partial compensation because the remaining value is moving in the opposite direction. Okay, very good. We're going to go to case study number 6. Case study number 6. Bear with me while I switch over here. All right. All right, quiet. Case study number 6. Our pH is 7.2. What are we going to give it?
A.
Good. Our bicarb is 58. What are we going to give that? The CO2. Did I say bicarb? I did. Do this. Yeah. I'm sorry. The CO2 is high, so what are we going to give that?
An
A. The PaO2 is 59, so still in the severe. And then our bicarb here is 24, so that's actually within normal range, right? Within normal limits. So we know that this is a
respiratory acidosis.
Respiratory acidosis. We know that it's not fully compensated because the pH is not within normal limits, so we could take full compensation right off the table. Is it partially compensated, guys?
No.
No. How do you know that? I agree with you. Because the bicarb is within normal limits. If there was partial compensation, it would be moving in the opposite direction to buffer. All right, good. Case study number 7. All right. So this one, we have a pH of 7.39.
Within normal limits.
Within normal limits, good. Our PaCO2 is 38.
Normal.
Within normal limits. Our PaO2, is 44. Not good. NG, no good. And then our bicarb is 24, so that's within normal limits. So, and I'm sorry, I don't know your name, but you had asked earlier sort of where does the O2 fit into the piece of the puzzle. In this case, we have a normal, for the most part, set of ABGs. The compensatory mechanisms perhaps didn't kick in yet, but I would imagine this would be somebody with an acute problem like a PE. And they just, it hasn't disrupted their acid-base balance yet, but they are clearly not oxygenating their blood, okay?
What was that?
That would be no.
Well, I mean, if you were to look at the gases and take the O2 out of the picture, those are normal gases, right? If you didn't have an O2 value, you were only given the other 3, those are normal arterial blood gases.
Yeah.
But we don't label it as anything because the gases, we label it as severe hypoxemia.
Okay.
And we have to get the patient oxygenated. Okay. Case study number 8, thank you. Case study number 8. So this one, our pH is 7.36. So what are we given that? Within normal limits. Our PaCO2 is 58. Acid, right? Because this is an acid. The higher the number, the more acid. Our PaO2 is 50. So again, severe. And our bicarb is 33. So that is base. Oh my goodness. So now what do we do with this, guys, right? We have things moving in different directions. So how you're going to analyze a blood gas like this is the value that falls midway between 7.35 to 7.45 is 7.4, okay? Anything less than 7.4, we're going to consider falling on the acid side. Anything greater than 7.4, we're going to consider falling on the base side. So this one was, what did I just say it was? This is
7.36.
7.36, thank you. So 7.36 falls on the acid side, right? So what matches it? The respiratory. So this was a respiratory acidosis, but guess what? It's fully compensated because the pH is within normal limits. Okay, so just go, when you have gases like this, go midway between 7.35 to 7.45, just remember is 7.4. Anything less than 7.4 falls on the acid side, anything greater than 7.4 falls on the base side. Okay, let's do 9. So here we've got case study number 9. pH is 7.5. B, agreed. PaCO2 is 28. B. The O2 is 85. Finally, we have somebody that's normal here. And then metabolic, the bicarb is 24. Within normal limits. So again, what follows in the same direction as the pH. So it's respiratory, alkalosis,
No compensation.
no compensation, very good. And how did you know that?
Because.
Third value is within normal limits, right? It's not moving in the opposite direction to buffer. Very good. Okay. Guys, was that case study 9? We're doing 10 now?
Yep.
Thank you. All right, so case study number 10, our pH is 7.2. What are we giving it? An A. Our PaCO2 is 28. B. Good. Our PaO2 is 81. Good. And our bicarb is 18. A. So which follows in the same direction as your pH? Very good. So metabolic acidosis, and our pH is not within normal range, so we could take full compensation off the table. But is there partial compensation?
Yes.
Yes, there's partial compensation, and why again? Because the remaining value is moving in the opposite direction in an effort to balance and buffer and correct the underlying acid-base imbalance. Very good. Okay. Is it making more sense, I hope, at this point?
Yes.
It is, okay. It seems like you're with me, but I don't want to assume if you're not. All right, case number 11. Our pH is 7.57. We're giving it a B. Our PaCO2 is 46, so we're giving it a A. Very good. Our PaO2 is 87. We'll take a nice normal there. And our bicarb is 38.
B.
So we're going to give that a B, and what follows in the same direction. So it's metabolic alkalosis. We know it's not fully compensated because our pH isn't normal. Off the table that comes. Our remaining value is in the opposite direction, so we know that means partial compensation. Okay, you got it. You got it. You got it. You got it. Yes, so you're going to go back to our discussion last class, the metabolic alkalosis and acidosis, okay? Now, let's just go through these. I really do think you have it. Let's go through a few really fast, so I know you have it before we move on to COPD. God bless you. If I can get this.
No, we got to that part with the case study. Yeah.
Why is it doing that? Oh, no. Okay, so let's look at this just quickly, guys, just so we can hammer it home. All right, so let's look at the first one. The top one is done for you. You have just put an A above the pH of 7.3. The CO2 is 35, right? So that's normal. Yes?
Are we going to be tested on like signs and symptoms and nursing interventions for like metabolic and respiratory acidosis and alkalosis, or just this? What we're doing?
You will be tested on both because the first half of the class was that.
Okay.
Yeah, and then the second half is really just interpreting it. So, and even on the boards, most likely you'd be given a set of gases. And there's a mix on our exam of you'll just interpret it. You'll just say what it is. And, but there may be a question or two on, you interpret it and then determine what intervention you're going to do. So if you interpret it as respiratory alkalosis, for instance, then you know that's associated with somebody that's hyperventilating. Then your intervention is going to be geared towards slowing their breathing down. You know what I mean? Does that make sense? Okay. That answers it. Okay. So let's just go through these quickly, guys. So the CO2 is 35, we're gonna put normal above that, and then the bicarb is 20, so that's acid. So the first one is metabolic acidosis, no compensation. Now look at the second one and tell me what you think it is. Look at your pH. pH is 7.48, give it whatever you think, your A or your B. Your CO2, give it your A or your B or normal limits if that's what it is. And then your bicarb. And then tell me what your analysis is of the second one on the slide. Metabolic alkalosis, no compensation. Good, good. How about the third one? Third one down, pH of 7.3. It's respiratory acidosis, and is it compensated? No, no compensation, because that remaining value is within normal limits. How about the last one, guys? Respiratory alkalosis,
No compensation.
no compensation. Good.
The remaining balance is within normal limits. Not compensated.
And let's see, this is 22 to 26, so that's within normal limits. Yes, no, it's within normal limits. It would have to be going in the opposite in order to have partial compensation. The last one? Okay, so just to recap, again, in terms of compensation, it's only fully compensated if that pH is within normal, and partially compensated only if that third value is moving in the opposite direction. All right, let's do these.
Can you repeat those, please?
Yes, it's only fully compensated. Is that what you want me to repeat, that part?
Just the second or the third and fourth examples we did.
Oh, I'm sorry, back here?
Yeah, I'm sorry.
No, it's okay. I'm sorry, which ones did you need? Third and fourth? Of the previous?
Sorry, I'm up there. It's not. The third and fourth.
Okay, so respiratory acidosis, no compensation. And respiratory alkalosis, again, no compensation.
Thank you.
You're welcome. Another way you can check yourself, like if this whole, the fully compensated is the easiest of the bunch because either the pH is within normal or not. So that one's easy enough to determine. Where it gets a little fuzzy for people is whether it's partial compensation or no compensation. Another way to sort of double check yourself is to know if there's partial compensation, all three values would be abnormal. And if there is no compensation, only one value would be within normal limits. So it's just a way to double check yourself. All right, so take a few minutes to work through these problems. Help the person next to you if they're still fuzzy, but just take a few minutes to work through these, and then I'll have you tell me what your interpretations are. Yeah. Help a neighbor if it's fuzzy for them.
I have a question. I was doing the sheet that you posted with.
I did post that sheet as I think Felicia Capulich is gonna do it in lab with you tomorrow.
I just want to ask something. So there was just.
There was a mistake, I think. Wonderful.
Yeah, there were all like, acids, and I'm like,
Yeah, it's a mixed disorder, and that's beyond the scope of what we're doing.
okay.
Yeah, send that to me though, so I can put an announcement out, so people aren't going crazy with it. I meant to take that off, actually. Just out of curiosity, how many of you feel like you got a good handle on interpreting it? Good. Okay, all right. Please help the people next to you. Not everyone's got it yet. If you need help, put your hand up. partial compensation, good. Because that CO2 is moving in the opposite direction, very good. Would you come up with the second one?
Metabolic alkalosis, partial compensation.
Excellent, metabolic acidosis, partial compensation. Metabolic acidosis, partial compensation, and we know it's partial because our remaining value is moving in the opposite direction. How about the one in the middle, the third one down? Metabolic alkalosis, partial compensation, excellent. The second to the bottom, respiratory acidosis with no compensation because that remaining value is within normal limits. Well done. And then the last one, metabolic acidosis, no compensation because the remaining value is within normal limits. Very good, very good. All right, and then this one is just another example. This pH, your pH is 7.37 here. We know the normal 7.35 to 7.45. So where does that fall? It's within normal range, right? pH O2, 35 to 45 is the normal. This is an acid, so the higher the value, the more acidic. So we're giving this A. And then the bicarb, the normal is 22 to 26. This is a base. The higher the number, the more base. The lower, the more acidic. 22 to 26. Where does this one fall?
B.
B. We're going to give it a B. So this is another arterial blood gas like the one we did earlier. What's midway if we're trying to figure out what the primary problem might be? Midway between 7.35 and 7.45 is what again? 7.4. So anything less than that is going to be A. Anything more than that is going to be B. We have 7.37. God bless you. So it is A. Right. So that's your primary problem. Is respiratory acidosis. Is it fully compensated? Yup, you know that because pH is within normal range. Good, very good. All right, and this is the PaO2 that determines hypoxemia, and we talked about this, and respiratory failure. If the PA, there's a term you might hear people use, particularly in the ICU unit. They might say a patient belongs to the 50-50 club. Not a club any of us wants to belong to. That's someone whose PaCO2, their carbon dioxide levels, are very high. They have respiratory acidosis. When I say high, I mean in the 50s. We know normal is 35 to 45, but somebody who has a PaCO2 in the 50s and they have severe hypoxemia, their O2 levels are down in the 50s as well. Someone who's going to be mechanically ventilated, somebody who's going to be intubated and placed on mechanical ventilation. They are not oxygenating. O2 sat, I'm going to move past. All right, so I know that made your heads hurt. Why don't we take 10, come back, and we'll get rolling with COPD. All right? To keep them out of the hospital as best we can. The problem with COPD, it's an umbrella term, asthma falls under it, but we're going to talk today specifically about chronic bronchitis and emphysema. And most patients with COPD have elements of both of those disorders. And we'll talk about, what differentiates the two. But if it's a chronic disease with bronchitis and emphysema, it is a chronic progressive illness though. So each time they have an exacerbation, they lose a little ground. There is no cure. They will continue to lose more and more lung function. They have irreversible damage to their airways. And so the end point for them, sadly, is death, unless they have lung transplantation, which will buy them some additional time. So at this point in time, no cure. It is a progressive disease. It is chronic. Just like with asthma, a big part of our role as nurses is going to be teaching them about how to self-manage their illness at home. The good news is, if it's good news, I don't know if you'll perceive it as good news, but the good news is the drug therapies that we use for COPD are the same ones we use for asthma. You're not learning all these new drugs for COPD. It's the same families, it's the same members members of the family's collection as used for asthma. So again, umbrella term, chronic progressive disease characterized by exacerbations and remissions. We're heading into cold and flu season, so we're going to begin seeing patients in with exacerbations of COPD if you haven't already. All right, so I included the objectives. I'm not going to read them to you, just for your reference. So this again is a problem with airflow that is irreversible because of destruction done to the airways over time. It too, like asthma, is characterized by inflammation, which narrows those airways. There is a strong correlation here with smoking and secondhand smoke. They, just like patients with asthma, will have trouble with bronchial. Hi, Professor Bunn. Yes, did you have an asthma? Yes, of course. You look like one of the students.
Who is Camila Carrera?
Oh, right here.
Can I talk to you
Yeah.
outside, please?
Okay. Yep. All right. So airway inflammation, bronchoconstriction. The medications are the mainstay of treatment. What medications relax that smooth muscle again? Open up bronchodilators. The SABAs, right? Those are our rescue inhalers. The SABAs. Inflammation. What do we use for inflammation? What drugs? Steroids. And how do we give steroids? Inhaled. It can be a meter dose inhaler, right? How else do we give them? EO, prednisone, and IV when they're in the hospital with their exacerbations. All right. The chronic bronchitis, this is an individual who typically has a cough that lasts from 3 months or 2 consecutive years. That's considered diagnostic of chronic bronchitis. The problem is people sort of blow off their quote-unquote smoker's cough, so by the time they seek medical attention for the cough, the disease oftentimes has been present for a number of years, 5 to 10 years in some instances. So a lot of times the damage has already been done. Emphysema, this too is someone who's a little more on end stage. This is the individual who has what we call air trapping. So they can get air in, they can't get the air back out again. So the air gets trapped in those little air sacs, the alveoli. Their lungs get really hyperinflated. And so all COPDers live in a chronic state of respiratory acidosis because they can't blow that CO2 off. They have air trapping in their lungs. Okay, bless you. I just included, just for review of your A&P, as we're referring to respiratory structures, I just wanted to throw that in. But basically, you remember your trachea is the main trunk of the tree. Remember your 2 bifurcations to the right and left bronchi, the major large airways, which then bifurcate into the branches of the tree, the bronchioles, and the bronchioles terminate in the alveolar sacs. For chronic bronchitis, the damage is really to the bronchi, the larger airways, as well as the smaller branches, the bronchioles, whereas emphysema is more the bronchioles and the air sacs. Someone with with chronic bronchitis rather, is going to have a chronic cough. If you were to look at them in terms of how they appear to be heavy set. Do you ever see people who have sort of a grayish, bluish tinge to their skin? Their color is not good. They tend to have cyanosis in their nail beds. Whereas somebody with end-stage emphysema, you've seen these people, out in the mall or at church, they tend to be very thin and frail in terms of their physical makeup. Both will most likely be oxygen dependent. Okay, so COPD, significance, you're not going to be tested on this certainly, but just to give you a sense, it is now I'm trying to think of where I got the information, National Institutes of Health, I believe is where I got it, and the CDC. So COPD is now the third leading cause of death in the United States, and it's the fourth leading cause, I'm sorry, it's the other way around. Sorry, fourth leading cause of death in the United States, third leading cause of death worldwide. And certainly with COVID, individuals who have a comorbid pulmonary condition, chronic condition, whether it's asthma, COPD, doesn't matter, they were at greater risk for hospitalization, and they had less good outcomes. Individuals who have COPD are encouraged to get a COVID vaccine, a pneumonia vaccine, and a routine annual influenza vaccine. They are also recommended to stay away from sick people, which is hard to do, I know. But in the height of cold and flu season, they should try to avoid crowds as best they can. And the mortality rates with COVID, with COPD were higher, but again, it was highest in your people over the age of 65. So those were old stats on the slide, ignore them, I gave you the current, and you're not going to be tested on those. So in terms of the etiology, certainly leading cause of death and disability in the United States and globally, again, affects older people in general. The incidence between men and women is fairly close, but women have higher mortality rates. Do you know why that might be? I'm sorry, say it again. I thought I heard.
Something with their anatomy.
It is something with their anatomy, exactly. Their airways are smaller in diameter to begin with than our male counterparts. So our airways, when they're limited, we're going to have less good outcomes. So you're exactly right. The diameter of the airway is smaller to begin with. And we live longer than our male counterparts, so we're more apt to have other comorbid conditions. So that eats us out in terms of mortality with COPD. As I've said, it is not curable, unfortunately. The primary cause in most of the cases is indeed cigarette smoking, so we're going to talk about how to help them with that. It can be exposure to occupational irritants, indoor or outdoor air pollution, and then for only a very small percentage of patients, this runs in families, they have an alpha-1 antitrypsin deficiency where their liver doesn't make basically a protein that protects the lungs. And again, thankfully that's rare. So again, smoking is a risk factor. Frequent exposure to smoke, it can be secondhand, it can be cigarette, it can be pot, whatever. We don't know yet on vaping. I think, their research is ongoing. It's just too early to call it. No one has been able to draw a direct line between COPD and vaping as a risk factor. I would think, given that you're inhaling something foreign into your airways, that it's likely 10 years from now they're going to say there is a connection between vaping and COPD. We just don't have that data yet. Long-term exposure to chemical irritants, again, in the workplace. Asthma, again, is a risk factor. And then short-term exposure to high levels of irritating substances. So an example of the final bullet on that slide is like our first responders. They weren't exposed over a long period of time to irritants, but when our first responders got to ground zero, they had such a high exposure in that one hit that they had damage, within 1 year out, they had damage that was the equivalent of someone with 12 years of exposure to respiratory irritants. So it was significant for them. Okay, so cigarette smoking, Does all the things we talked about with asthma and with coronary artery disease for that matter. So it increases our heart rate, it causes peripheral vasoconstriction, we basically poison ourselves, right? Carbon monoxide has a higher affinity for that hemoglobin molecule. So remember the Ferris wheel, it has all the seats on the Ferris wheel, or most of them. So the person is not feeling generally well because of the carbon monoxide issue. They have a lower oxygen carrying capacity, so they make them feel not so good. They also have this hyperplasia of the goblet cells that line our respiratory tract, which contributes to mucus production, which is a big part of the problem for them. Loss or decreased ciliary activity. We see this in our folks with chronic bronchitis. Remember the cilia where those tear-like projections that beat upwards to remove foreign invaders such as bacteria and viruses? Those become paralyzed with nicotine. I will say you can recover function of the cilia if you quit smoking. So there's always benefit to quitting smoking. Destruction of the alveoli, that's what you're going to see in the patient with emphysema. Those air sacs, those tiny little air sacs at the end of the bronchioles become overinflated, gas exchange becomes impaired, and then chronic inflammation is, again, within the airways, narrowing the diameter of the airways. So again, another mainstay of treatment is going to be steroids. We talked about secondhand smoke, reduced pulmonary function, and more respiratory symptoms. So when they're coughing and they have all this mucus production, they're at greater risk for respiratory tract infections. Because the cilia problem, we lose that protective benefit, but it's also, mucus is a really good medium for bacterial and or viral growth. So the fact that they always have mucus around places them at greater risk. How would we know if an individual has a respiratory tract infection? What are the key manifestations that you would see?
Productive cough.
So a cough, and if they're at baseline always coughing, because remember they cough for 3 months, right, at a time for two consecutive years. If they're coughing all the time, it's a change in their normal cough pattern. They're coughing more. What else? The color of the sputum. Yeah, the color of the sputum changes. What else is indicative of infection? Fever, aches, yeah, all of those things. Okay? High white blood cell. Their white blood cell count would be trending up. So we have to teach them, because again, they're self-managing at home. As nurses, we have to teach them those symptoms that they can recognize and immediately notify their healthcare provider. Okay, in terms of prevention, refrain from engaging in behaviors linked to the disease, which of course is smoking. We'll talk more about that in a minute. Decrease exposure to secondhand smoke, pollution as best you can. There was an interesting study that was done out of Johns Hopkins on Hispanic patients, Latinx population, in that they had less good control of their COPD, and when the researchers did the deeper dive, what they found was those patients were not being provided literature that was culturally appropriate. They weren't being provided literature that was in their preferred language. And so, as a result of the study, globally, more attention has been given to providing literature, again, in the individual's preferred language. Clinical manifestations, again, with simple bronchitis without disability. So it can go the whole spectrum from, their home, carrying out their activities of daily living, they're still working, they don't need any help with anything, but it can go all the way to the other end of the spectrum where they can't do almost anything for themselves. You will have COPDers in the weeks to come in the hospital who literally, like, brushing their hair is exhausting to them, or brushing their teeth is exhausting to them. So you're really going to have to help them manage their ADLs until we can get them out of the exacerbation. The end result is going to be, sadly, respiratory failure. It's a horrible death. I wouldn't wish it on anyone. They have an awareness of it. I can't imagine living with that awareness. But at the end, they suffocate. I mean, that's how they die. That is not that we get to choose how we die, but that's certainly not the way any of us would choose to die. We look at forced expiratory volume, FEV. One is the volume of air that's forced out into a spirometer in 1 second. And we compare that with the symptoms they're having, and that gives us a sense of how severe their illness is. Again, for many years, their symptoms are pretty mild. They have it, but they just don't know they have it for a long time. And by the time they get diagnosed, the permanent damage to their airways is done, unfortunately. How many people do you know in your families or loved ones or friends who smoke and they kind of blow off their smoker's cough, right? When it could be something more. As the disease progresses, they're gonna have more dyspnea. Remember, dyspnea is difficulty breathing. When we talked about asthma, the hallmark of asthma was wheezing, right? The hallmark for COPD is dyspnea, it's difficulty breathing. And you'll see the nurses will document a change in pattern here too. So if at home, normally, you have, a little bit of dyspnea with mild exertion, but suddenly you have dyspnea at rest, that's a change in your pattern, and that's a reason to notify your healthcare provider, right? You're not tolerating activity as well. You're losing a little bit of ground. So again, something we just have to teach our patients, and you'll notice the nurses, when they document, will be very specific about the dyspnea, right? They have dyspnea with mild exertion, dyspnea with moderate exertion, dyspnea at rest. And if somebody has dyspnea at rest, they're really struggling to breathe. Their gas exchange is pretty impaired. So chronic bronchitis, again, this is the individual who's got this terrible cough. There's a lot of mucus that they're expectorating. I don't know if you're familiar with the word tenacious. I don't know if that's a new term for you or not. If it is, it just means sticky. It's mucus that's really sticky and inherent, which makes it difficult to get it out of the airways. Our goal really, I'm going to say 1,000,000 times in our time left together, our goal is to mobilize secretions. We want to get the secretions out of the smaller airways into the larger airways so that they can cough the secretions out. So that's, the thick tenacious sputum is difficult because it's so adherent and sticky. So long as there's no contraindication, the nicey, nursey way to get around it is to give them fluids. The fluids will help liquefy that sticky, icky, tenacious sputum, get it into the larger airways where they can expectorate it. Okay, cyanosis we talked about, and for the student who learned blue bloater and pink puffer, the blue bloater came from this terminology, right? They tend to be bigger in appearance and have cyanosis. We don't teach them separately anymore because people have elements of both. They will have evidence of right-sided failure. This is on another slide, but you can write it here for now. It's called cor pulmonale, C-O-R, cor pulmonale. Do you remember from Professor Parada what those symptoms were, right-sided heart failure? I know the left side is like all your pulmonary stuff, right?
Systemic.
Edema,
Ascites.
ascites, hepatomegaly, right? The liver's tucked up, it's in your right upper quadrant, tucked up under your rib cage, so they have hepatomegaly, edema, and JVD. Yeah, those are all signs of right-sided failure. And these folks will develop right-sided heart failure or cor pulmonale as the disease progresses. It would be right-sided because with pulmonary disease, there's an increase in pulmonary bed pressure. And if there's an increase in pulmonary bed pressure, the right ventricle has to work really hard to overcome that higher pressure. And like any muscle in your body, if it has to work harder, it's going to hypertrophy, right? So the right ventricle hypertrophies, trying to overcome the increased pulmonary bed pressure, and it will hypertrophy and fail. It won't move the volume forward. What happens when volume can't move forward? The ventricle dilates, remember, like heart failure, and then the right atrium, same thing, is going to fail because the volume's not going forward. And then you're going to have all that jugular vein distension and the hepatomegaly edema. No, good question, thank you. All right, so right-sided heart failure, and you know how to treat that. We treat it the way we treat heart failure always. Adventitious lung sounds. Sometimes their breath sounds are diminished. Somebody with bronchitis has bronchi, that really harsh, hoarse-sounding lung sound. People with emphysema, because of the air trapping, they have hyperinflated lungs, and over a period of years, it actually changes the structure of their whole upper body, their whole thoracic, the rib cage. There's increase in what we call, you'll see the doctors write it in the H&P as an increased AP diameter. All they mean by that is an increase in anterior to posterior diameter. Just means that it's increased, it's wider. They become barrel shaped. Their upper body looks like a barrel. It's round. And so when you're trying to auscultate those lung sounds, it's so hard to hear them. They sound really far away, and they are because the lungs are so hyperinflated. Okay, so there, we talked about dyspnea being the hallmark, barrel chest. Tripod position is, you really don't have to teach it to them. They'll do this on their own, just trying to get air out because it's trapped. But tripod position is just, they're sitting with their knees flexed and their feet on the floor like this. And typically what they'll do is place one hand over the other like this, and they kind of like lean forward with their mouth open. It's just desperation trying to get air out. And it's tripod because this is 1, 2, and then this is the third piece of the tripod. And I'll show you a picture of some of you in tripod position. But for those of you who have taken care of COPDers with exacerbation, typically when you go in to do your initial assessment of them, almost always, where are they sitting? How are they positioned? Has anybody taken care of somebody with COPD?
Like on the bedside table, bent over.
They're sitting, yeah, they're usually either sitting up on the edge of the bed with the pillow, with the bedside table here and a pillow on it and their arms folded in front of them. Or they're in the, if we can get them, it's hard to get nice chairs in the hospital sometimes, but if we can get them a nice lounge chair, a lot of times they like to sleep in the lounge chair. They prefer to sleep in the lounge chair. So you will not be finding them flat in the bed when you come in to assess them. All right, and we're going to talk about the calorie demand increasing because there's so much work that goes into breathing. They are using accessory muscles and literally 24/7, using every muscle in their body to try and breathe and try and get that air out. It consumes a tremendous amount of calories. They end up losing a lot of weight, and so we'll talk in a little bit about how we manage their nutritional needs. And then anxiety. I mean, obviously, if you can't breathe, you're going to have a degree of anxiety, and that certainly is understandable. Okay, so as we've said, the manifestations develop slowly over a period of years. They will present with symptoms of chronic bronchitis, usually initially, and then later emphysema. Chronic bronchitis is characterized by that cough, as we said. Dyspnea, the hallmark of COPD is dyspnea, so put a little next to that. And cyanosis. Stasis of mucus, again, a great culture medium for bacterial and or viral growth. So our goal is really to have them avoid sick people. Tachypnea and noisy breathing. You can hear wheezing on some of them without a stethoscope. They will use open mouth breathing. And I'll show you a picture of clubbing of the nails. And then orthopnea, do you remember what orthopnea is? Can't lay flat. Cannot lay flat. All right, and then we talked about their right ventricular failure, and I just put here the JVD, hepatomegaly and edema. We talked about their barrel-shaped chest, that increase in anterior to posterior diameter. That's because of those hyperinflated lungs. And then we do, as nurses and respiratory therapy as well, teach them how to breathe slowly through pursed lips in an effort to get air out. So it's just a very small opening in the mouth. It's almost like you're blowing through a straw. And oftentimes you don't have to teach it, they do it automatically. If you've ever known anyone with COPD or ever taken care of a patient with COPD, pay attention to how they're breathing. Almost always it's very small opening in their mouth, they're trying to blow air out. And then chronic cough and shortness of breath. So remember I talked about the tripod position? This gentleman is in the tripod position. His feet are on the floor. Unfortunately, you can see he still has his pack of cigarettes here with a lighter and his ashtray, unfortunately. I think that you have to tell your COPDers, I think some of them have that fatalistic thought of, you know, I've got this terrible disease now, the damage is irreversible. Well, I enjoy smoking. I like it, I enjoy it, I'm gonna smoke. There's no benefit to quitting now. The literature is very clear, there is always benefit to quitting smoking in terms of improving one's quality of life. There's always benefit, doesn't matter how advanced the disease is. Is it gonna reverse the disease process? No. But is it gonna slow the progression? Yes. And if I have a chronic disease that's going to kill me, I want time with the people I love, right? I wanna slow that progression. But, you know, quitting smoking is a hard thing to do, and we're gonna have to really support them through it. So they have, this gentleman, you can't really see it with his shirt, but people with end-stage COPD have retraction of the supraclavicular. Supra just means above the clavicle fossa. That's, I think I'm too fat to show it to you. I'm gonna try. It's this, like here. I know how that goes in. So you see them, when they breathe, that really indentation kind of sucks in because they're really trying to lift up that rib cage. The shoulders heave upwards on inspiration, and in advanced emphysema, they're using all of their accessory muscles, their abdominal muscles and the muscles around their rib cage. This is a picture of clubbing. It's from chronic hypoxemia. So the club obviously is an increase in the size of the ends of their fingers. It is irreversible. But again, just another manifestation of the disease. In terms of the history and physical, you're going to see your doctors write in the H&Ps about their pack year history. All they mean by that is, for instance, a 20-pack year is someone who smoked 1 pack of cigarettes a day for 20 years.
I thought it was 20 packs a year. I was like, that's nothing.
No. Yeah, so it's the number of packs per day times the number of years, yes. Yeah. All right, so ventilation and perfusion, they will have a mismatch with ventilation and perfusion. This just basically reflects how well the lung tissue is being ventilated or not. The serum alpha-1 antitrypsin, that's that weird thing that runs in families. It's a genetic thing, but it's only about 1 to 3% of the cases. But they certainly are more predisposed to the development of COPD because they don't have that protective protein for their lungs. ABGs, we certainly talked those to death, didn't we? But these guys would have respiratory acidosis because they're retaining CO2. They get air in, but they can't flow that CO2 out. But because it's a chronic condition, you will see their bicarbs running at about 26 or higher. Because remember, the kidneys take longer to buffer, but they can hold the buffering for a longer period of time. O2 sats, the CBC, we're looking again at that white count trend. Chest x-ray if we're concerned about a pneumonia. Pulmonary function test, the forced expiratory volume, the FEV1, again, is done in the pulmonary lab. It's the amount of air they blow out forcefully into the mouthpiece of a spirometer in 1 second's time. We compare that ratio with the forced vital capacity. The forced vital capacity is the total amount of air that they can blow out. So FEV1 is what they blow out in 1 second. The forced vital capacity is what they blow out for the full breath. And then we look at the ratio between the two. Basically, if it's less than 70%, that's diagnostic of COPD. The lung surgery, we can do, if the patient qualifies, we can do lung transplantation for patients with COPD. I will say, you know sometimes how out of bad comes good? I will say before COVID, we did not do a lot of lung transplantations for people with COPD because a lot of them were too sick to qualify to get on the list for the organ. But because of COVID, not that I wish any of us to have gone through it, but because of COVID, what we found was that even the very sick patients with COVID made it through their lung transplants. Not only did they make it, they thrived. We began using ECMO, which is basically like an artificial lung. ECMO had been around for probably 70 years. We hardly used it before COVID, but then in COVID, because we were losing so many people, mortality rates were staggering, we began using ECMO. And what ECMO also does simply is takes the patient's blood, does what the lungs would do, oxygenates the blood, gets rid of the CO2. It basically does what a healthy lung would otherwise do. That's all ECMO is. So what ECMO did in COVID, for people who were, so I hate to say it, but circling the drain, no other way to say it, people who were really decompensating, what it did was buy them time to either wait to get the lung, because it takes time to be on that wait list. And in some cases, it bought, like your younger people, it bought them time for their own lungs to heal. And out of bad comes good. We learned a lot in COVID. The other thing we learned about lung, I think in your nursing practice in years to come, you are going to see lung transplantations done. I think the guidelines are going to change because there was a lot of people that prior to COVID would not even have gotten onto the list. But now we have good data that shows they could have and maybe should have been on the list. So the guidelines will change. And that's good news for somebody with this, with this disease process. They can be single or bilateral in terms of the transplants. Typically they're single, and that's more because of the, lack of organs. But the survival rates are really impressive. And what we learned through COVID the hard way, because there were so many people having lung transplantations, anytime you have a situation where we're doing more of something, the surgical techniques get better, the anesthesia techniques get better, we figure out how to manage them post-transplant better too. So I do believe in your nursing practice you will see more lung transplantation. I think you'll see COPD be better managed. The lung reduction surgery, that's where they take a portion. Remember I was saying end-stage emphysema, or lungs get really hyperinflated. And so they'll take the most diseased portion of the lung, hoping that the remaining lung will then help the patient oxygenate better. I would say it's still experimental at this point. I wouldn't say that's being done as a mainstay of treatment. And then I did have, not that again I would test your room, but out of interest, there was a study out of Johns Hopkins. The average, not tested on this, they looked at 250 patients who had COVID. The average age for the lung transplant was 52, so they were relatively young. 21% of them were females, 36% of them were Hispanic, and they recovered beautifully. Their survival rates were over 95%. It's really impressive. So hopefully we'll see more of it. All right, in terms of pharmacotherapy, you recognize these players. Nobody new here, no new members of the family. Everybody gets a SABA, everybody gets a rescue inhaler, short-acting albuterol. We use LABAs as well with COPD, the anticholinergics, and the combination drugs. Same players for the same reason. We're still treating inflammation, we're still treating bronchoconstriction. And then again, just the inhaled corticosteroids. We know that at home, when they're self-managing, they'll have higher and higher doses of inhaled steroids. When that doesn't work anymore, They'll be put on an oral prednisone. If that doesn't work, then they've got to come into the hospital for the IV steroid, just like asthma. They'll go back home on their oral steroid. So oxygen therapy, this is the only treatment really that has been proven for people with COPD. It's the only treatment of them all that really improves their survival. Supplemental oxygen. It is for severe and prolonged hypoxemia. It does improve their exercise tolerance and their mental functioning. Chronic CO2 retention has an adverse effect on brain function. The name of the game is to improve their quality of life. I mean, we want to help them live as best they can with this chronic illness. It certainly reduces their frequency of hospitalizations. Can be used intermittently. Some of them just put it on at night. They have extension tubing so they can get in and out of the bathroom. And we can get them extension tubings in the hospital too. If we ambulate them in the hallway, we're going to use a portable tank. It's not important, you're not going to be tested on liquid or compressed gas, but that's generally what's in the house, gas cylinders and concentrators. Now, the challenge with oxygen therapy is this. For you and I, for all of us sitting here today, hopefully we all have normal lung function, right, as far as we know. So for us, our drive to breathe is going to be abnormal PaCO2 levels. That is what is going to be the stimulus and the message that's sent to the respiratory center in our brain. All right, so for healthy, quote unquote, normal people, our stimulus to breathe is going to be the CO2 levels. However, for COPDers, these guys chronically retain that acid. They can't, remember, they've got hyperinflated lungs, they can't blow out that CO2. They chronically hold on to CO2. So what happens is the respiratory center in the brain gets desensitized to that as their stimulus to breathe. You with me? So for them, their stimulus to breathe is going to be a low oxygen level. All right? So even though we treat them with oxygen because they have hypoxemia, we have to be careful not to give them too much oxygen because it can remove that stimulus to breathe. Let me say that again, or
Can you say that again?
Absolutely, absolutely. So in health, our stimulus to breathe is abnormal PaCO2 levels. If our acid levels are high in our bloodstream, the message is going to go to the medulla, the brainstem, to encourage us to breathe. That's going to be our stimulus to breathe, to get rid of the excess acid, right? For someone with COPD, they chronically retain that acid because they can't blow the CO2 off. It's all trapped in those hyperinflated lungs. So because they can't blow the acid off, they live in a state of chronic respiratory acidosis. So the brain, the medulla, the respiratory center in the brain gets desensitized to that as a stimulus to breathe. So for them, their stimulus to breathe is going to be a low oxygen level, hypoxemia. And even though we treat with oxygen, it's usually, those of you that took care of COPD, it's usually around 1 to 4 liters that they're on basal cannula. If we give them too much oxygen, we can remove that stimulus to breathe. They call that oxygen narcosis. And so what would your patient look like if we somehow gave them too much oxygen? They would be very lethargic for one, and they would have reduced respirations or bradycardia. Okay, so we would most likely have to either get them to ventilate better, or there's a couple of ways we can go. So there's a question about what if they're really hypoxemic, and here's where it gets a little sketchy. If they suddenly really desap, they decompensate, you're gonna see the respiratory therapist put something like, if they're really low, they might put a non-rebreather on them. And you might go, holy crap, why are they putting a non-rebreather on this person? It's because they've desatted so quickly, they need to get their oxygen level back up quickly. But here's the caveat. The caveat is, even if you give them the non-breather, as much oxygen as you can give them, you're gonna get them off that mask quick, you're gonna get them, titrate them back down to their baseline quickly, and you're gonna have to assess the respiratory status closely in the meantime. Now, sometimes we had a patient last semester, was desatting, respiratory came, we did the non-rebreather, got the oxygen level up, we started, but every time we tried to titrate patient off the mask, he kept decompensating. So we ended up, the respiratory therapist put him on CPAP, that mask people use for sleep apnea, forces air into your lungs. It's non-invasive ventilation. And so we did the CPAP, and we were able to get the patient better ventilated, and the patient was oxygenating better. We were able to then get the patient off the CPAP and back onto their oxygen. If the CPAP didn't work though, the patient would have to be intubated. Because the CPAP, it's non-invasive. You're not putting a tube in somebody's throat, it's the mask you're putting on their face. But if that CPAP doesn't work, that's the doorstep to ICU. If that doesn't work, then they've got to get the tube in the throat, and they've got to be mechanically ventilated. They're hard to take care of. They're a real challenge to take care of.
What is the concern?
So we like to see them, the guidelines say an ideal stat for them is between 88 to 92% because of the chronicity of their illness. So anyone who's less than 88 would be a concerning stat for them. And the guy we had, we pulled him off the stretcher from the ED, and he was statting in the 70s. He was circling in pain for sure. We had to move quickly. Okay, so that's oxygen therapy. Airway clearance, we don't do this as nurses, our respiratory therapist colleagues do this, but the whole goal of airway clearance therapies is just as their name implies. The name of the game is to get the mucus out of the smaller airways into the larger airways so the patient can then get it out. So we nurses can teach effective coughing, they call it puff coughing. It was in your book, in your assigned reading somewhere. But puff coughing is, you have the patient just sitting in the chair, which they're probably sitting in the chair anyways. Their knees are flexed. They're gonna flex their head slightly forward. They're gonna take a breath in, and then they're gonna blow out like that, like a huff. It's similar to, if you've ever seen somebody clean their glasses, they kind of go on their glasses to fog them up and clean them, or you can do it on a mirror. That's all a huff cough is. It's not rocket science. It's just a way to help get secretions out of the smaller airways. So if you can teach them how to do puff coughing, it just helps with mobilization of secretions. I'm going to talk about chest physiotherapy on the next slide. The high frequency chest wall oscillation. Those of you at Hospital for Special Care, and probably Gaylord, I would think, see patients with this apparatus. They have this device around their thoracic cavity. It's attached to these I wanted to say pipes, but that's not the word I want. Hoses. It's attached to the hoses, which is attached to a machine. Basically vibrates the chest wall, again, just to mobilize secretions. Get the secretions out of the small airways, into the bigger airways, and hopefully up and out. And then percussion would not be done by us as nurses. It is done by our respiratory therapy colleagues. They cup their hand like you see in the picture, and they tap on the patient's back. This again is to mobilize secretions. If done incorrectly, you can actually cause trauma to either the anterior or posterior chest wall. You can fracture a rib if you don't know what you're doing. So I very happily leave that to my respiratory therapy colleagues. Vibration, they use a similar technique. It's the same thing as the vest. It's to really just mobilize secretions. Postural drainage, respiratory therapists will position the patient, reposition the patient. It's just allowing gravity to get the mucus out of the smaller airways into the larger airways. So our goal is, patency of airways, obviously, facilitate drainage of mucus, get it out, and then huff coughing is here, we talked about that already. Other interventions, smoke cessation, really hard to do. The guidelines actually say, and I hope this, I'm gonna ask though, 'cause I'm just curious. So the guidelines say that every patient, regardless of your health, history, physical, whatever, every single patient that seeks health care should be asked about tobacco use. And if you use it and you're willing to quit, you should be counseled to do so and given the resources to do so. So just out of curiosity, you've all at some point seen a healthcare provider, hopefully. How many of you were asked by your healthcare provider specifically about tobacco use? Ooh, that's impressive. Good, that was actually better than I thought it was gonna be. Excellent, excellent. Kudos to them. And how many of you that raised your hand were offered assistance if you wanted to quit? Okay, so good. All right, I'm glad. Okay, so quitting in the hospital, we use patches. We start usually with 21 milligrams. We do 21 milligrams for 7 days, then 14 milligrams for 7 days, and then 7 milligrams for 7 days and off. Nicorette gum, I believe, is sold over the counter now. I'm pretty sure it is. But there's a variety of ways. The physical addiction to nicotine is gone in 3 days. So the physical, and I'm not saying the physical addiction is easy to beat, but it's the psychological addiction that's much, much harder to deal with. And so we can use a variety of drugs, Wellbutrin and Zyban among them. They're antidepressants, they help elevate the mood. People enjoy to smoke. I mean, it's, and when they lose that, it does affect their mood. So we use these antidepressants pretty effectively. I'd say I see Wellbutrin more. Nortriptyline, this one is Hamelar is the trade name for it. It's really to reduce the anxiety and stress around the psychological dependence on it. And then Chantix is the only one that acts on the brain to block that pleasure from nicotine, and it releases a little dopamine. It has some serious side effects. Yep, it does. So if you're thinking about Chantix, take a look at the side effect profile. Yeah, there's a lot of side effects. There's a tobacco quit line I gave you. There's an app that people can put on their phone because when you quit smoking, you're often looking for something to do with your hands. So they can actually, and to distract your mind too. So there's games on the app that you can play. Do things, the nicey, nursey things to tell them to do is, go for a walk, exercise when you're feeling, like you want a cigarette, meet a friend who doesn't smoke, go see a movie, whatever, distractions. It's all distractions. Yes. I agree. So your classmate up here is saying that oftentimes there's habits that go along with, you associate smoking with. Sometimes you enjoy it after a meal. Some people enjoy it first thing in the morning. Some people like to light up right when they get out of work. So it's always it's the psychological dependence that's hard to beat. For anyone who's quit, does anyone want to share what was effective for you or most effective for you?
I use Chantix actually.
You did use Chantix.
It was the only one, I tried it all.
Yep.
For 10 years I tried to quit smoking. Chantix was the only thing that worked for me.
Yeah.
But I've also had friends who use Chantix and, had severe depression and suicidal tendencies and things like that. So you'll know pretty quick when you take it apparently whether you're going to go for the routine on Chantix.
Yeah.
But I had no side effects other than like really vivid dreams.
Oh, my dad had those, he said they were gnarly.
I actually really enjoyed it. I've heard people call them suicide nightmares, but I have the kind of stuff you pay money to see. I like it. That's just me.
Should write that down.
Yeah, I wish I had kept a paper on the side of my bed. And then you get up to go to the bathroom, you go back to sleep, you go right back into the dream.
That's so
So Chantix work. Anyone else? What worked for you?
Yeah.
Yeah,
And I was on the 21 milligram patch for about 3 weeks
wow.
and still chewing gum. And then I kind of went to the course. I was on the patch for about 3 months, but I finally quit after 40 years.
That's a long time and good for you. Probably the hardest thing you've ever done.
Absolutely.
Yeah.
Well,
Yeah.
other than that.
Oh, come on. What's so hard about all this? Everyone's gonna be asking for Chantix now. All right. So in terms of, thank you for those of you who shared what worked for you. That was really helpful. I appreciate that. So in terms of complications, we talked about right-sided heart failure because of the increased pulmonary bed pressure, pulmonary hypertension. It's a late manifestation of COPD. Dyspnea, just put a star next to it, hallmark of COPD, just like wheezing is the hallmark of asthma. Hepatomegaly, that's associated with right-sided failure, peripheral edema, and leaking. Diagnostics, nothing new here. Certainly chest x-ray to see what precipitated the exacerbation if it's pneumonia, so we can treat accordingly. Right-sided cardiac cath, if we suspect cor pulmonale or right-sided failure, ditto for the echo. The BNP levels, we know we check that in individuals who are worried about heart failure. ABGs we've discussed ad nauseum, and pulmonary function tests. So again, because it's a chronic condition, how do we teach them to manage the condition at home? Knowledge is power. I can't stress enough how important it is for you to teach them about their meds, how to use their med therapies, but to recognize when they're in trouble and when to notify the healthcare provider. One of the things that people with COPD suffer with is that overwhelming sense of powerlessness to the point where they feel like the disease is controlling them and not the other way around, like they have no control of the disease. So we want to empower them. Knowledge is power. We want to teach them how to manage their condition at home. And that's, hard to do, but important. So it's going to be exacerbation is signaled by a change in their baseline. They're always coughing, but now they're coughing more. Or they've got more sputum, or there's a change in the color of their sputum. Or they were dyspneic with exertion, with moderate exertion, now they're dyspneic at rest. There's a change in their baseline pattern. And again, the big offenders are bacterial and viral infections, so we're going to tell them to vaccinate, as I said earlier, pneumonia, COVID, and help me, influenza. Thank you, garden variety influenza, the flu shot. We almost forgot about the flu with all the COVID. Signs of severity, use of accessory muscles, central cyanosis. The treatment is what we certainly have discussed already. The complications, the worst case scenario is respiratory failure. We're going to talk about that on Thursday. ARDS and respiratory failure. We have to be careful with sedatives with them and benzodiazepines because it can adversely affect their respiratory pattern. So we just have to, we can give them, we're not going to, opioids too. If somebody with COPD has surgery, we're going to give them opioids. We're not going to let them, be writhing in pain in bed, right? So we are going to give them the opioids, but as nurses, we do have to monitor their respiratory status more closely than any other patient population. They are a little more challenging that way. Same with benzodiazepines. Like we give Ativan for patients who are withdrawn from alcohol. And alcohol withdrawal, delirium tremors, no joke, it could kill someone. So we have to give them Ativan. If somebody has COPD, but they also have a problem with alcohol, we have to give them the Ativan because the DTs can kill them. So we're going to give the benzodiazepines, we're going to give the opioids, we have to monitor their respiratory status more closely. Oxygen therapy we've talked about. Our goal really is 88 to 92%. That range is what the guidelines say. And we talked about the benefits of long-term oxygen. It improves their quality of life. Nutritionally, we said that they have, because they're working so hard to breathe, they're using all those accessory muscles, they will lose weight rapidly. So we want them to have basically a high calorie, high protein, moderate to high fat. We don't want high carbohydrate because it increases their CO2 load. We want foods that don't require a great deal of chewing. Like if you think about a piece of steak, that would be exhausting for them to chew and chew and chew. All of their energy goes into breathing. So give them soft high protein, might be like cottage cheese with fruit in it, or the Greek yogurt with fruit in it. Things that are easy for them to manage.
So do you want them on a moderate to high fat diet?
Moderate to high fat, yes.
Okay.
Yeah, just not high carbohydrate.
Is that something where you want to tell them to also avoid low density?
What do you
Or no?
mean?
Does LDL or HDL matter?
Saturated fats.
Well, I mean, I hate to say that at this stage of the game, but
At that point, it doesn't matter, it's more like.
you're just trying to keep weight on them at that point?
Okay.
Yeah,
Yeah.
yeah. There's actually a supplement, Ensure, Ensure that puts out the supplement. Ensure has a formulation that's specific to people with COPD. The exercise and treatment should be an hour before or after eating. We don't want to do postural drainage on someone and they're coughing up all that mucus and then put the tray in front of them to eat. That's not very appealing. And we want them to avoid gas-forming foods. In terms of your elderly, they're at greater risk because of their multiple comorbidities and their issues with polypharmacy. They have multiple healthcare providers, and sometimes the right hand doesn't know what the left is doing. So they have also some cognitive deficiencies that makes management of their own routine at home difficult. They also have less elastic recoil in their pulmonary system. Their chest wall tends to be a little stiffer. They don't expand as fully as we do, as you do when you're younger. So they have a little stiffness in their chest walls. That's a normal physiologic decline with aging. And again, their symptoms may be missed because some of them, like fatigue and activity intolerance, are associated with aging. Right, is their CHF getting worse, right, versus, yeah, it is a challenge when they've got multiple comorbidities. In terms of the nursing process, I'm not going to read this to you, it's pretty straightforward. It's things that we've talked about in terms of helping them manage at home. The assessment, again, not going to read this all to you, but mostly we've talked about everything here, taking a good history, getting their smoking history, getting them resources to be successful, hopefully in quitting. These are the problems. These should make sense to you. You can use this. You will be caring for patients with exacerbations in the weeks to come as we head into cold and flu season. Certainly use these on your boxes page. Breathing pattern ineffective, and it's ineffective because they can't get that CO2 out. They have air trapping, hyperinflated lungs. Their breathing pattern is ineffective, which is going to also alter their gas exchange. Airway clearance ineffective. Think about your person with bronchitis. All of that coughing, all of that mucus certainly can adversely affect their airway clearance of larger airways, smaller airways. Activity intolerance because of the impaired gas exchange. Again, you're going to have to really help them with ADLs. Imbalanced nutrition, less than body requirements because of all that workload on breathing. And that's why as nurses, remember in the cardiac unit, we talked a lot about reducing the workload on the heart. In the pulmonary unit, a lot of what we've talked about here this morning has been about reducing the workload of breathing for them. And then family coping compromise. If you know anyone who's been a primary caretaker for someone with COPD, it's very stressful. They do have a change in their personality. Some of it is because of the CO2 effect on their brain. Because they're fighting so hard and focused so hard on breathing, they can be short with you. They're not patient because, again, they're working so hard to breathe. I certainly understand it. This is where we plug in our nursing empathy, and none of us can imagine what it must be like, obviously, for them. Planning, these are things that we talked about, so I'm going to move past it. Implementation, I just want to note on the first bullet here, it is appropriate to increase fluids so long as they don't have a comorbid heart failure. They don't have poor pulmonality. So for somebody with early disease or moderate disease, you certainly can and do increase their fluid intake to liquefy that thick, sticky mucus so they can get it in out of the smaller airways into larger airways and out. High fowlers, we want them sitting up in bed. Honestly, you're never going to have to worry about it because you're going to find them up in their chair or sitting at the edge of the bed with their arms folded in front of them in the bedside table. We're going to do frequent respiratory assessments. This is definitely the patient you want to pull in your instructor and say, I don't know what I'm hearing, I can't hear anything. So pull us in and let us come in and listen with you because it's very hard to evaluate their lung sounds because of that barrel chest. We will also help you, well, now you know how to analyze ABGs, but if you have any question on ABG analysis, certainly we will guide you. They may be on daily weights and I&O, administer their expectorants and bronchodilators. They will be on Mucinex too, just like our patients with asthma. And then we're going to provide the supplemental oxygen as needed. This is, again, nutrition. The lab value probably we would monitor would be the albumin levels just to see how deficient they are. We would consult with a dietitian, our registered dietitian colleague, for advice on getting the right snacks to them in between meals. Family coping, again, they need a lot of support. The American Lung Association has support groups. I would refer patients and families to it. That feeling of powerlessness and helplessness, again, we want to teach. Knowledge is power. Ambulatory care, pulmonary rehab is, if they qualify, if they have insurance, that's a consideration as well. Pulmonary rehab is very helpful for improving their quality of life. It's mostly run by respiratory therapists and nurses, and they will have the patient exercise, but they will monitor very closely their response to exercise. They will work with the patient. Do you remember which member of the healthcare team works with patients trying to adapt their activities of daily living? OTs, yeah, our occupational therapists. They are brilliant at coming up with ways for the patient to conserve oxygen and still get through their ADLs with some level of independence. Sleeping is a problem because it is a chronic, debilitating, deteriorating, progressive disease. They fear going to sleep. They're afraid they're not going to wake up. And so sleeping is problematic for them. Again, a lot of it is positioning and getting them support that they need, the emotional support that they need. We do come to that point in the road where we do have to discuss end of life. We'll call in a palliative care consult, and we'll begin discussing hospice. I know most of us, when we think about hospice, end of life care, we often think about, somebody with cancer, but a lot of patients in hospice are end-stage COPD as well. And it's a hard, obviously, conversation to have, but it's better to have the conversation sooner rather than later. You have these really, if you have any friends who work in ICU, you have these situations where somebody ends up on a ventilator for extended periods, and it's not probably what the person would have wanted in the end. Their quality of life is they're not going to die with dignity, I'll say that. So it's best to have these conversations sooner rather than later, as difficult as they are to have. And then this is, again, I just included this for your boxes, pages on your clues. Feel free to copy it right on over in terms of expected outcomes for them. And here's some additional outcomes as well. And then finally, telemedicine, we've gotten better in part due to COVID again. So out of bad comes good again. We've always had telemedicine for a long time, but we've used it more since COVID, and the technology is better. So I keep saying about managing their disease process at home. We have the technology now where the patient can get up, slap on the blood pressure cuff, get a blood pressure. They can put on their oximeter, get an O2 stat, get their heart rate. All of that data is inputted to the healthcare provider. They also have a machine where you can, the visitor nurse will fill the machine with the pills and the inhalers and whatever it is they need for the day. And the machine will actually talk to the patient and say, it's 2 o'clock, it's time for your whatever inhaler. So it really makes the patient feel like they're not alone in all of this, and it keeps them more connected to their healthcare provider, and the healthcare provider will recognize if there's a change in any of their trends in terms of their vital signs, in terms of how they're feeling, in terms of their symptoms, and so forth. So telemedicine has been hugely, hugely helpful in reducing their hospitalizations. So I'm sorry I went so rapidly, but any questions on COPD? Okay. I'm gonna let you go. I know you have enough to do. You gotta prep tomorrow for your lab, so I'll let you go and do that. Please bring your art PowerPoint class on Thursday.
Oh my god. I'm literally sitting here. I'm just like, I don't want to be here. I just want to go home. It's fucking cold.
I'm like thinking about what I'm gonna do next.
Sweatshirt or something.
Yes.